Good evening, everybody, and welcome to my IVF Answers platform and the European Fertility Society, which has been created to support, raise awareness and educate patients struggling with fertility. My name is Rachel Sherriff and I will be your host for today. I'm the founder of the Fertility Suite, a holistic fertility clinic in Surrey, London. And today, joining us, we have Dr. Elias Tsakos, who is the Medical Director of Embryoclinic, which is based in Thessaloniki in Greece. And the topic we'll be discussing today is invasive medical procedures and how they can support fertility. This event is going to be recorded. It is anonymous. The recording will be available tomorrow on the My IVF Answers platform and on the YouTube channel. And we are going to start with a presentation on our topic, and there's going to be 3 to 4 real-life cases, and then we'll follow the question and answer session afterwards. I'm going to open the chat section shortly, and you'll be able to post your questions as we go through, and then we will come to them at the end when we'll have the chance to answer your questions. So with that, I will start the presentation and hand over to you, Dr. Tsakos. Thank you for joining us.
Thank you, Rachel. Thank you, everyone, for attending this time of the day, this time of the year. So I will try to be short and sweet. The topic of my presentation is the importance of assessing the uterus, assessing the anatomy before we embark on IVF. And in particular, there's a lot of pathologies, a lot of abnormalities that we need to address. And it's not just IVF that treats everything. It's also the importance of addressing the uterus as a factor of success. So this is the main topic of my presentation. So I will introduce you to fertility surgery, what it is, and I will go through 3 very nice, very interesting cases, very glorious, successful cases that we had the privilege to contribute in their success. And of course, we're going to have the take-home messages at the end. So what is fertility surgery? Before we mention the 3 types of minimal access fertility surgery, I will talk to you about the importance of the uterus. I mean, the uterus is the incubator. It's the human incubator. It's a magical organ which constitutes of the endometrium, the lining, and also the muscular layer around it. So the normal uterine anatomy and functionality are vital in order to accommodate the growing fetus. And there's a lot of gynecological conditions that may affect the uterine anatomy, some of them congenital, some of them acquired, some of them age-related. And the fact that we're treating older and older patients, or reproductively older patients these days, make those conditions even commoner and makes it imperative that we address, diagnose, and manage and treat those issues before we embark on IVF. So there's a dual contribution of fertility surgery. One is restoring the fertility, and that includes both natural fertility and assisted fertility. And of course, the second contribution is by improving and alleviating chronic clinical symptoms like endometriosis or myomas or polyps that may produce debilitating symptoms. So we treat the woman as a whole. We treat the woman, we make the woman healthy. We make her enjoy the healthy stages during her everyday life. And of course, on top of that, invariably, this improves the fertility outcomes, either natural or assisted. So what are the options? I mean, until recently, well, I will go back until maybe 40 years ago, 50 years ago, in the 70s or early 80s, there was none of that available. It was only laparotomy. And thankfully, the last 40, 50 years, there's been a huge progress in the hysteroscopy and laparoscopy option. And recently, in the last, I would say, 10, 15 years, some people would say 5 years, we have robotic surgery, which is the evolution of laparoscopy into more advanced technologically equipment that allow us to perform better surgery, if you like. So hysteroscopy, this consists of the term hystero, which is the uterus in Greek, and oscopy, which means visualize. So we visualize the internal cavity of the uterus, the endometrium. This is a fairly new technique. It's been around for, I would say, less than 40 years now. And of course, it's been improving over the years, and now we can not only observe, but we can also treat conditions in the inside of the uterus. And that includes fibroids, congenital anomalies, polyps. You see a nice polyp here, adhesions, and sometimes myomas, which are entering the uterine cavity. So with the hysteroscopy, we can visit, we can assess, and we can diagnose and treat any abnormality that is located within the endometrial cavity, which is the part of the uterus which is the most vital in terms of achieving a pregnancy. Laparoscopy has been around also for 40, 50 years. It has evolved. We have better equipment year in, year out. Our skills are becoming better. And until recently, it has been the evolution. It has been the method that has moved us away from large laparotomy incisions into keyhole surgery. And I said until recently because a few years ago in the USA, maybe 10 years ago, in Europe, I would say 5, 6, 7 years ago, we have started using also robotic surgery for more complex laparoscopic surgeries. So this is the assessment of the pelvis and the peritoneum, is the gold standard for diagnosis and treatment of endometriosis. It is performed by 4 or 5 small incisions, less than 1 centimeter, and the recovery is pretty quick. Now, robotic surgery is the advancement of laparoscopy. We have this piece of equipment, which is the 4th generation robotic system. It all started in around about year 2000 in the US. There have been trials before that with different systems, but the current system started its evolution in around about 2000. In 2005, it received the FDA approval. It started becoming widespread in the USA in 2010, 2015, and it moved over to Europe in the last, depending on the country, 5 to 10 years. In Greece, we've been very fortunate to have robotic surgery since 2006. And in my department, we have been seriously working with robotic surgery for about 6 years now. So we've had, we were amongst the first in Europe, if you like, in continental Europe, to use this technology, which is magnificent technology. What does it do? There's improvement in every aspect of the technology we've been using. So improvement in the control, in the movements, in the vision, in the excision, in the 3D visualization, in the detection of nodes. We can be more precise, and we can thoroughly excise the abnormal pathology and spare the normal pathology. Now, I get asked many times. I mean, I've been a laparoscopic surgeon longer time than I had been a robotic surgeon. I've been a laparoscopic surgeon for nearly 30 years and robotic surgery for about 6, 7 years. And they ask me, what is the difference? And, why, can't you do it laparoscopically? And the answer is very simple. I give them the example with a city car and an SUV. I mean, if you want to go downtown, all you need is a city car. So that's a laparoscopy. So downtown driving is small pathologies, for example, small fibroids, small cysts, perhaps very simple endometriosis that can be treated. But then when things get harder, when you have multiple fibroids, when you have massive endometriosis, stage 4, when you have difficult patients operated on many times, with a lot of adhesions and a lot of technical difficulties, this is when you need the equivalent of the SUV advanced technology in order to perform the surgery. So the benefit of robotic surgery is more evident in complex surgeries. And believe me, some of the fertility surgery can be very complex surgery, and can be much more complex than cancer surgery, for example. I mean, and this sounds very strange to many people, but it is true. Complex endometriosis and complex multiple myeloma surgery is a very complex surgery, because not only do you need to excise adequately the lesions, but you need to also preserve the functionality of the organs. And in particular with the myoma surgeries, the functionality of the uterus. And with robotic surgery, we can push the boundaries even further. We can operate what used to be inoperable in the past. And even today, we get referred patients with multiple myomas, 3, 5, 10, 15, 20. It doesn't really matter the number. Sometimes you can have very challenging surgeries with 4 myomas, if they're big, if they're stuck, if they're combined with endometriosis, if they're distorting the cavity. And if you have patients of advanced reproductive age, where you want to do the surgery as pristine as possible, and then you want to get them back on the fertility route within 6 to 8 months, and you want to make this uterus pregnant and delivering. So it can be very challenging. So the commonest applications are fibroids, endometriosis, congenital abnormalities, and intrauterine disease. So these are the main indications of fertility surgery. Of course, there's also 2 more that one of them has become more or less obsolete, which is the tubular anastomosis, because it is not that common anymore to receive patients with tubal issues that want anastomosis. Nevertheless, this can be done laparoscopically and robotically. And of course, the pinnacle, the ultimate fertility surgery procedure is uterus transplantation, which sounds very futuristic. However, some very bright minds in the world, they managed to perform that successfully more than 10 years ago. And that was the first successful uterus transplantation performed by laparotomy, of course, not by minimal access surgery 10 years ago. And I have been fortunate enough to be closely involved, not in the beginnings, but in the last couple of years with that amazing team. So we're hoping that uterus transplantation, which is a celebration of collaboration and teamwork, will become one of the standard procedures for absolute uterine factor infertility. So either for women who are born without a uterus, in the cases of MRKH, or for women who have lost their uterus through surgery, or with women with incurable Asherman syndrome and intrauterine adhesions. But this is beyond the scope of my talk today. However, I could not resist to share my newest passion, which is uterus transplantation. Fertility surgery, real patient stories. I mean, endless stories. I mean, my team and I, we've been very fortunate for many reasons, but one of those reasons is that we managed to keep very high standards of fertility surgery. We kept our skills, we kept our technology up to date, and we kept busy, which means that we constantly perform fertility surgery, which is a skill that has to be retained. And at the same time, we run a very busy IVF clinic. So we've had the privilege to see the patients all through the surgery and IVF success. So I was spoiled for choice to choose those cases. Of course, they're anonymous, so I know them only too well, but of course they're anonymous. But I can share with you that we had a case of a 39-year-old woman with a 45-year-old husband, been trying for 3 years. They had a history of polyps and DNCs. They had failed IVFs in a different clinic with implantation failures. So that patient went through investigations for the implantation failures. And one of the investigations, which was the high-end ultrasound scan, which is the 3D ultrasound scan that we performed in our clinic, showed suspicion of intrauterine adhesions. For the people listening in, I would like to mention here that there's two types of ultrasound scanning. One is the standard ultrasound, the 2D standard machinery and equipment and expertise most of us have in our clinics. But there's also advanced ultrasound, just like in obstetrics, in pregnancies. You may be aware of advanced obstetric ultrasound scanning, which is done by experts and with the use of high-end equipment. Similarly, in gynecology, there's advanced ultrasound. Here you can see a glimpse of a picture of a 3D endometrium, which is a little bit thinner than it should be for the time of the cycle. So one take-home message is that a standard ultrasound may not pick up uterine anomalies, and it's the advanced 3D/4D ultrasound scanning approach performed by highly specialized individuals, trained, certified, and experienced in identifying uterine anomalies. And of course, with the use of very high-end equipment, this is the only way we can diagnose uterine anomaly. So following that, we jointly decided that, the couple and ourselves, we suggested hysteroscopy. We moved forward, done a hysteroscopy, and indeed there was presence of intrauterine adhesions. Now, adhesions is scar tissue, is abnormal tissue, is tissue that is associated with either failure of IVF or miscarriages. And it is not always easy to treat adhesions, but in this occasion, we were fortunate that the adhesions were not very widespread. They were localized, they were thin. So we managed to treat those adhesions via operative hysteroscopy and restore the uterine cavity. So following that, the couple came back for IVF, the endometrium looked normal, and they had a successful outcome. I mean, I'm sure that most of my IVF colleagues, my fertility colleagues, and my minimal access surgery colleagues, they've been through similar cases. So it's not, it's not publishable, it's not that rare to publish, but I thought it would be interesting to present to you tonight. Teaching points here. I mean, this couple, presumably they could have IVFs forever, but with failed IVFs. And unless we address the issue of endometrial factor infertility, perhaps that couple would not have benefited from our management. So I think the take-home message is that although we have become, pretty good in assessing the quality of the embryos, we should not forget the importance of the endometrium in the IVF success. So that's the teaching and take-home message. Now, this is another case of a 46-year-old woman with a 51-year-old man, been trying for 6 years, many fibroids, lots of fibroids. They had multiple IVFs, and even with egg donation, they didn't succeed. And also the woman had a history of iron deficiency anemia, menorrhagia, and painful periods, and also painful pain on intercourse. Now, fibroids, very common, become commoner now that we're treating women of older, of more advanced reproductive age. May I add here that the age limit in Greece is 54 for the female, and there's no upper age limit for the male. I would say that roughly, perhaps, 40-50% of women in their late 40s, early 50s would have fibroids. Thankfully, the majority would have fibroids not big enough to warrant surgery. It's a very difficult consulting patients with fibroids. To be honest, we see a lot of fibroids in my clinic. We run a specialist fibroid clinic. We try to assess fibroids as much as we can with 3D, 4D ultrasound scan. We believe that this is superior to an MRI scan, and of course, much less expensive. We check other factors like location, like blood flow, like elastography. Sometimes we perform tumor markers as well, because we're very well aware that not all fibroids, the vast majority are benign, but not all of them. Perhaps roughly 1 in 3 to 400 may be malignant. And in that case, we're talking about a malignant sarcoma that we really need to diagnose beforehand, and it can be disastrous if we miss it. We probably pick up one every year in my practice. Thankfully, we've never had unpleasant surprises, which means that sometimes sarcomas are picked up on histology. So all of the cases we treated so far, we knew there were sarcomas and we managed them accordingly. So that was a similar case. We've done all we had to do preoperatively, and then we decided to operate. There's various approaches all over the world, all over Europe. My approach is very simple. If I cannot explain failure by other means, then I know only too well that fibroids reduce the chance of implantation, successful implantation, even smaller intramural fibroids, 2, 3, 4 centimeters. So, we've done extensive counseling to that patient, and then we resorted to robotic surgery. That was not a very challenging case. However, it's always challenging if you have a 46-year-old, you want to do perfect surgery, you want to restore the uterus, you want to suture it in as many layers as possible, you want to retain the blood flow to the myometrium, and you want to make this uterus functional again. And for those medical, because I can see some wonderful medical people in the audience, the biggest nightmare of a surgeon is that phone call in the middle of the night about some woman in pregnancy with complications after laparoscopic or robotic surgery for myomas. Again, thankfully, and thank God, we've never had a similar case. We've never had any either uterine rupture or uterine complications after robotic surgery, but we're very, very well aware that this is one of the risks. So it is complex, demanding surgery that has to guarantee quick recovery so that the woman can go on to IVF, and of course then they would have to go on to successful pregnancy. So the outcome here was a favorable outcome. In about 4 months' time, the couple were matched with the donor. We carried on egg donation to that couple. Although we had planned the embryo transfer at 6 to 7 months, eventually there was a delay beyond our control. So at 9 months, we did the embryo transfer, and we had a positive pregnancy test that resulted to a healthy pregnancy and a healthy delivery by cesarean section. The majority of our fibroid surgery patients, we suggest a cesarean section because we don't feel confident of having those women with all that scar tissue in their uterus to undergo vaginal delivery, plus other associated factors with age and so forth. So the teaching points here is that this patient clearly had a uterine factor infertility. Thankfully, it was not an absolute uterine factor. It was a relative that was treated successfully with robotic surgery. And success story number 3 is a younger woman in her 40-year-old, 5 years infertility, endometriosis. Very typical endometriosis. Endometriosis is a very challenging. I strongly believe that endometriosis and fibroids can be very, very challenging in women wishing to retain their fertility. It takes a lot of counseling, it takes a lot of investigations, it takes a lot of multidisciplinary meetings, a lot of imaging in order to understand what is the best way forward. Here, advanced ultrasound can also be very helpful. And in our department, we have amazing people giving us all those information about the staging, the location, and the severity of endometriosis, which is helping us map our surgery and plan our surgery properly. This particular case we thought could be managed by laparoscopy, so not robotic surgery. As I said in my introduction, if it is possible, we prefer laparoscopy. My team and I, we have now performed very near 10,000 endoscopic cases, and most of them are conventional laparoscopies and hysteroscopies. So we feel very confident, and of course, it's the cost issue that we want to avoid for our patients. So if we feel that we can manage laparoscopically, then we suggest that, and that was the case here. There was a lot of adhesions at this stage. There were some endometriosis foci that were resected, that were removed, and the patient was discharged. It was not easy surgery. I mean, I remember quite a few times during surgery, I mumbled that perhaps I should have used it, but never mind. It went very well. So the couple came back. 10 months later, we did ovarian stimulation, and with the frozen embryo transfer, frozen thought embryo transfer, we were successful. So the mechanism by which endometriosis resection, excision, improves fertility is not 100% clear, but certainly there's an element of reduction in the inflammation, in the inflammatory response that definitely plays a role. Teaching points here that laparoscopy, conventional laparoscopy still is the gold standard in the assessment and treatment of endometriosis, perhaps for easier endometriosis, for earlier stage, although there are some amazing people who have stopped, amazing surgeons who have stopped using conventional laparoscopy, but they only do very advanced robotic surgery, which is something I fully respect. In our practice, we still use conventional laparoscopy if we feel that we can give top quality service. But my feeling is that in the next perhaps 5 to 10 years, conventional laparoscopy will be fully replaced by robotic assisted laparoscopy, if not fully robotic, but at least some sort of hybrid system that would give us better access and better treatment. But of course, this remains to be seen. And the combination of fertility treatment also alleviates chronic symptoms. So let's not forget that although fertility is the primary presenting complaint of our patients, also restoring their quality of life should be very high on our agenda. And in this patient, we managed to achieve both. So take-home messages. I have a passion for surgery. I started as surgeon, and then I moved into IVF, and then I moved back to surgery, and now I've been very fortunate, my team and I, to perform both. In my opinion, the only way to stay at this level is to have an amazing team, and to be honest, I'm very grateful to my team who have been so supportive. And there's 6 gynecologists in our team. Half of them are very good surgeons, and we perform surgery together, and the other half are very good IVF people. On top of that, having the expertise of advanced ultrasound scanning, of counseling, of multidisciplinary team meetings with the patients, I think makes it very important, of course, together with pathology, with imaging, and so forth. Fertility surgery can be a cost-saving and cost-effective option in the long run as well. So, some patients, they may not even need to resort to IVF, and these are patients we celebrate even more. And there's many of our patients who just need surgery instead of IVF, and that is on its own the only intervention we perform in the fertility management. Fertility surgery constitutes the only ART treatment option that combines improvement of both fertility and clinical symptoms. It is a myth that IVF in pregnancy are the treatment of endometriosis, for example. No, I believe that surgery, mainly surgery, primarily surgery, excision surgery, is the gold standard for clinical symptom relief in endometriosis. But sometimes we need to, of course, combine the two. And equally, fertility awareness, if you like, anatomy awareness can help us understand what is the predominant component of our patient's fertility issue, and then by addressing that component, we put them one step closer to the success. So that is, I think, the end of my presentation today. Thank you very much, and I'm happy to take questions. Thank you.
Thank you so much, Dr. Tsakos. It's brilliant to hear surgery talked about in such a positive light with some success stories, because I think it's all too often we have sort of negative connotations around surgery. So it's really great to hear some of those success stories. Thank you. We're going to move on to the Q&A now. So first up, we have a question from Gronya. So she's asking about her chances of getting pregnant after bowel resection for endometriosis. She has previous unsuccessful IVF and egg donation, and she's aged 43.
Sure. Well, pretty good chances. I mean, bowel resection is becoming more and more common, because now we understand, in the last perhaps 5 to 10 years, we understand more about endometriosis, we diagnose more, and we treat more. So the chance of your success depends vastly on the quality of your uterus, and in particular the quality of the endometrium. And of course, from ensuring that there's no leftover endometriosis that may adversely affect implantation and pregnancy. So I would be very, very optimistic. I mean, I presume you've had very top quality surgeons dealing with your endometriosis. So I think they're the best people to ensure that your uterus is also in optimal shape, and egg donation can make miracles. So yes, I would be very optimistic, and I would challenge you that perhaps next year this time you will raise a hand and remind me that I told you this. And I would be very optimistic. I mean, in our practice, we've had many cases like you who did extremely well. Put it this way, from having a nodule of endometriosis on the bowel for the rest of your life is much better. The option of having bowel surgery, which is heavy surgery, is much better, A, for the quality of your life, B, for your fertility. So I would be very, very hopeful.
Thanks, Dr. Tsakos. I'm sure Gronya's happy to hear that, so thank you. This is from Vladana, what is your suggestion if someone has been diagnosed with Asherman syndrome?
Sure. Asherman syndrome can be very tricky. I mean, firstly, there's different levels, there's different classifications, and there's different degrees. So I would, to put it simply, I would find a very experienced hysteroscopist, and there are some amazing people around. And I would let them classify my Ashermans, and I would try my very best to improve. I mean, Ashermans, in my opinion, can never be treated 100%. You can never have a perfect uterus after Ashermans, but even an improvement of 50, 60, 70% may give you the opportunity of a pregnancy. So that may need repeated treatments, repeated procedures, repeated operative hysteroscopies. Thankfully, in the last 10 years, perhaps, we have better equipment, better technology. We can cut without cautery, which produces more adhesions. We can use at the same time ultrasound scanning, advanced ultrasound scanning, in order to sometimes we need to discover. It's like swimming in a cave, underwater in a cave. Repeated procedures, patience, understanding, the use of some material, anti-adhesive material we can use within the uterus. Maybe PRP, platelet-rich plasma, which there is evidence that it is giving us an extra bit of something. I mean, with Ashermans, you need to be positive. I mean, you really need to get in there and say, okay, I'm going to make it better, perhaps 15% better, 20% better, 25% better every time. And then also at some stage you need to say to yourself, okay, I'm going to stop here. I'm happy. I've got a 75% perfect uterus. And then I'm going to move on to IVF, or I'm going to leave alone for natural pregnancy and all that. So I would be, it's not like polyps where you can be 100% sure that you will treat them. Even fibroids, you can be 100% sure you will treat the intercavity fibroids. Ashermans can be unpredictable. It's like having a scar on the face. Even if you go to the best plastic surgeon, you will still have a small scar on the face, which perhaps is not that visible. But I think we're getting better. So I would be very, very optimistic. It takes time, patience, but overall, patients are doing very well. Then in pregnancy, again, you would need very high-end pregnancy, monitoring. It would not be a standard pregnancy. You would need a dedicated team to understand, to know what to expect, to support the pregnancy. Sometimes with Asherman surgery, and to be honest, in my practice, we have 3 or 4 such very, very challenging cases every year. We have many more, easier. But yeah, 3 or 4 challenging cases where after repeated surgery, the myometrium is very thin. So you need to monitor the thickness. Of course, you need to avoid twins. You need to avoid contractions. Sometimes we do even daily or, almost daily monitoring of the thickness of the uterus in order to understand and decide when is best to get in there and deliver the baby. So it is challenging, but overall, I would say the majority would do well. So I'm hoping that you would be one of them.
More positive news, thank you. From Nadine. Nadine has adenomyosis in the posterior wall of the uterus, and she'd like to know, what investigations would you recommend? She's had previously 2 unsuccessful transfers with good quality donor eggs. I think by the sounds of it, they were maybe early positive test, but chemical pregnancy.
Yeah, adenomyosis can be challenging also. In my opinion, 3D, 4D advanced gynae ultrasound scan is the best way to map it. Yeah. Sometimes, with the standard scan, it's actually very strange. I'm sorry I can't show you next door. We have a standard scanning piece of equipment, and then next door we have the advanced scanning, and it's like, day and night sometimes with adenomyosis. So I would strongly suggest advanced ultrasound gynae scanning to map your adenomyosis, to ensure it is adenomyosis. Sometimes there's myomas as well, or both. And then, of course, assessment of the cavity by hysteroscopy, perhaps biopsy of the cavity as well, of the endometrium. And then very good discussion. I mean, after the mapping, one has to decide what is the best way forward. I mean, adenomyosis can be a little bit of a nightmare for a surgeon. And we try to avoid surgery for adenomyosis unless we have to. I think it's a very difficult decision based on the extent, on the density, on the measurement and the value of normal myometrium, on the history. Yeah, you can't go on having unsuccessful transfers, for example. There's 3 types of adenomyosis in my opinion: black, gray, and white. If it's white as in small adenomyosis, localized, I would just ignore it. I mean, perhaps I would use frozen embryo transfer, and I would use a little bit longer down regulation in order to deflate it, if you like, for 2-3 months before embryo transfer. If it's huge, diffuse adenomyosis all over with lots of dense areas and all that, then, and with multiple failures in the past, then I would consider surgery, provided that there is healthy tissue, healthy myometrium tissue. Even if one cannot remove adenomyosis entirely, I think by reducing as much as we could the adenomyosis in my opinion, it would probably give us a better chance of pregnancy. But that can be very challenging surgery. And for that surgery, I would definitely use the robot. And then you have the gray, which you're not sure, something in between. Should I operate? Should I not? Generally, if I'm in that area, I prefer not to operate. I've had some amazing teachers repeating in my ear all the time that if you really want to be top surgeon, then you need to choose what to operate. So, I wouldn't jump in with adenomyosis. So I would be conservative. I would, again, use down regulation. Perhaps I would use PRP for the endometrium if I see glands of adenomyosis also evident with hysteroscopy. I would only operate after repeated failures. I mean, I know it's a little bit passive, but I would prefer not to operate if I'm not sure. If someone is, borderline for an operation, and of course I would listen to the patient's wishes. Yeah. In my experience, patients, they prefer surgery, but they don't know. We need to spend time to explain to them that, we may not be able to remove the entire adenomyosis. We may be faced with adhesions afterwards. We may have to wait for more than 6 months for the recovery myometer, plus the risk of rupture. So if they hear that, sometimes then it's becoming complex. So I think it's not easy. Adenomyosis is not easy. I would start with good mapping. Map. Have a very good ultrasound scan. Map your adenomyosis. Get a second opinion. Ask for MDT, multidisciplinary team meeting. Consider protocols of suppressing adenomyosis prior to embryo transfer.
Thank you. That leads nicely into the next question from Roxana, who asks how long to wait to do an embryo transfer after hysteroscopy to remove a fibroid.
Well, depends is the answer. I mean, if it's a straightforward, we call it type 0 fibroid, 6 to 8 weeks is more than enough. But then again, depends on the best person to ask is the surgeon, because it depends on how broad the base was. If it was a thin base, grade 0, fine, no problem. You can go within 4 to 6 weeks. If it's a broader base myoma, and if it's perhaps not exactly grade 0, if it's grade 0 to 1 or 2 sometimes, I would wait a little bit longer. If I'm in doubt, and very often I am, I have to confess, I suggest a second look hysteroscopy, office hysteroscopy. Put a scope in, have a look. If everything is good, just go ahead. But in general, I think a couple of months, 2 to 3 months is more than enough for a standard smaller, medium size, grade 0, figure 0 stroke 1 fibroid. I don't know if it makes sense.
Thank you. So a little bit more of an IVF type question and a few more IVF sort of questions now. So Kate has a 4-year-old child who she conceived via a donor egg previously, and they're now trying for a sibling. The embryos are PGTA tested, euploid. Unfortunately, they've had 4 unsuccessful transfers. So they've done quite a few investigations. They've done the endometrio, which corrected the implantation window. Kate's also been taking antibiotics for potential endometriitis prior to the frozen transfers. Also taking some heparin and aspirin for thrombotic factors. So she's had a hysteroscopy and it only showed a tiny fibroid and some cells with potential for endometriitis. The fibroid was intramural. Is there anything that might have been missed, or could a previous cesarean section have caused an issue? Is there anything else you would look for?
Sure. Okay. Difficult. Yes. I mean, firstly, I would do microbiome testing. I don't know if you've done that. Microbiome testing is like a genetic testing. You can Google that, microbiome. It's not microbiology. It's a little bit more advanced. We use more advanced technology, next generation sequencing. So microbiome testing. This may reveal either an infection that has not been shown in the standard microbiology testing, or an imbalance between the healthy bugs and the unhealthy bugs. So there's a lot of evidence. I mean, to be honest, it's not my first line implantation failure or miscarriage investigation, but I think in your case I would suggest it. So microbiome testing, that's one. Number two, I would get the best person, the most senior person in the unit. I would urge them to do the embryo transfer. I mean, I think this is a secret between all of us, not that well hidden secret, that embryo transfer is operator dependent. So, I believe that most units, and I have visited, perhaps more than 100 units in Europe in my time, and they do that automatically. When it becomes a little bit of a difficulty in achieving a pregnancy, they get the most experienced person. But I would ensure that the best, the most experienced person to do the embryo transfer for you, and equally the most experienced embryologist to handle your embryo. I think that's it. And then I would touch upon a little bit. I would touch upon on the immunology. I mean, immunology is a black box. It's a very black box. I can see Rachel smiling. My opinion, we cannot disregard it 100%. I mean, I know that most, there is a fight here. Most fertilities, most doctors, most gynaes, most fertility specialists, gynecologists, they disregard it because the evidence says that and all that. Of course, there are some amazing immunologists that raise the flags. I think the truth is somewhere in the middle. I believe that a small subgroup of patients, how small, I don't know, 2%, 5%, 10%, perhaps, may benefit from immunology assessment and immunology addressing and management. I think, and you may be in that subgroup. So I believe that immunology plays a part. I just feel that we haven't identified, perhaps we don't have the means to identify the technology at the moment, the knowledge, to identify which group of the patients perhaps may benefit. So, just approach that black box of immunology with a little bit of caution. Maybe there is a little element there, perhaps, because everything else we've done.
I think that was a very, very good diplomatic answer, Dr.
Yes.
But
microbiome, there's more evidence on microbiome, to be honest.
Yeah.
There's a lot of evidence. And also PRP. I mean, try PRP. To be honest, I don't know, Rachel, I've only known you for a little while, but, perhaps 2, 3, 4, 5 years ago in these webinars, I was very skeptical about PRP because the knowledge, the science was not there. Yeah. To be honest, I was forced, I was urged, I was motivated by my patients, which I'm very grateful to. Oh, come on, doctor, study it. I've seen this study. They've sent me so many studies over the years. And I was waiting for the evidence. And to be honest, I got convinced last year. There is evidence for PRP.
Do you think
it doesn't harm? But I think in your case, it may help. There is evidence. There's pretty good evidence for endometrial PRP, in my opinion, for patients like you. Sorry, Rachel.
Do you think in Kate's case that a previous cesarean section could be a contributory factor or could be causing any issues?
I think it's unlikely, to be honest. Having said that, I would exclude hydrosalpines, for example. I think the only way I can think of, in my mind, and I have worked with hundreds of gynaes, I've seen thousands, if not tens of thousands of cesarean sections, and most of them are done, I would say 99.9% are done perfectly. There's always the element of how women cure and how women heal. And there's individualization in the healing process. The only mechanism in my mind that the cesarean section could affect adversely implantation is the creation of niche, of a gap in the healing aspect of the cesarean section. I mean, you can Google that. Actually, we have published on that subject. So, but if that was the case, that would be evident on the scan. You would see it on the 3D scan. There's a little bit of a black spot just underneath the scar. So that may affect adversely implantation. And the second mechanism I can think of is the creation of hydrosalpinges. So there's a small risk, very small, I would say, I don't know, less than 1% risk of pelvic infection after a cesarean section. And if that has affected your tubes, and if you have hydrosalpinges, which is the accumulation of fluid in the tubes, that may adversely affect implantation. So if you want to explore that, again, 3D, 4D ultrasound scan, and if you really want to exclude it 100%, perhaps a HSG stereosalpingogram.
Thank you, Kate. Hopefully that answers your question. Next is more IVF related. So Ali's asking, they've been advised by their specialist to try using donor eggs. However, they'd like to try IVF just once. Would undergoing multiple stimulation, so back-to-back stimulation, increase the chances of a pregnancy? Or are they better off just doing a single stimulation cycle? And important to know their ages. So female partner is 45 and the male partner is 48. Difficult question to answer.
Yeah, okay, sure. I mean, we've been entertaining the option of back-to-back stimulations. Now, I don't know what she means by back-to-back, if she means like double stimulation every cycle, or stimulation every cycle. To be honest, in the overall outcome, I don't think it makes a difference overall. That's my opinion. At 45 years of age, female age, the main limiting factor is the DNA integrity of the embryo. So, in my opinion, it doesn't matter if you do it, back to back or not. It doesn't make any difference. If I were to suggest something, some intervention, that would be PGTA on the embryos in order to avoid either totally unnecessary embryo transfers or an embryo transfer of an abnormal embryo, which would end up in a miscarriage and all the associated psychological and physical impacts after that.
Thank you. So Gronya, who asked the first question about the bowel resection surgery, has just come back to say, yeah, she had a great surgeon. She had stage 4 endo removed off her bowel 2 years ago, and then the resection was 8 weeks ago. She said, thank you for your response, very positive. How long would you try to conceive naturally after surgery before turning to egg donation again?
To be honest, that depends on the condition of the tubes. So what I would do is I would very clearly discuss with the surgeon, what he thinks the condition of my tubes are. And if he feels that the tubes are normal or nearly normal, I would try definitely for a few months. Having said that, there's always a possibility that, and I don't want to scare anyone, but I have to share my clinical thinking that even if the fallopian tubes are normal during complex surgery, they may become scarred afterwards. So, if I were to rely on natural conception, I would not lose time without testing the tubes.
Great, thank you. I'm just asking someone to re-clarify their question because it's not clear. So we'll move on to another one. Goodwin is asking, following hysteroscopic adheliosis, what would you recommend as the best option of intrauterine anti-adhesion solution? It's a good question.
To be honest, whatever your doctor is familiar with, more or less they do the same job. I don't think one is better than the other. I'm not familiar, I'm not aware of any evidence, any comparative studies. So whatever your doctor feels comfortable with. Some people don't even use any gels and they're doing fine. Some people, because this is expensive stuff, so some people just reserve it for following the follow-up if they find adhesion recurrence and all that. Some others use a coil. Some others use PRP straight after the procedure. Some others use very inexpensive methods like a Foley catheter, a small balloon. I think whatever, Asherman's hysteroscopic surgery is very advanced surgery. I mean, it can be very tricky. It can be trickier than stage 4 endometriosis because, you're in the clouds and you don't even know where you are. And then, unless you put a scan on top, you don't realize sometimes when you're through the uterus and so forth. So it can be very, very tricky surgery. And there's a lot of good people out there. So I would ask performing that. So I would ask my surgeon to use whatever they feel familiar with.
Great, thank you. There are 2 more questions, but they're not very clear. So I've just asked the attendees to re-clarify. But I think what we'll probably do is wrap it up there and say that we will get the questions over to Dr. Tsakos and his team to reply to over email or via Caroline, who runs the webinars. But either way, we'll get your questions answered once they've been clarified. But yeah, thank you so much, Dr. Tsakos, for joining us. It was great to meet you.
You're very welcome. Thank you for the opportunity. I mean, if I want to sum up, I will give you the example. Fertility is very simple. You need a top quality embryo. And we've become very good in that. I mean, if you see our labs now and you saw Joy, you will understand why, Joy the film. So we need a top quality embryo, and we have all the means of ensuring that. Own eggs, own sperm, donor sperm, donor embryo. So we can meet that obligation to offer you a top quality embryo. And then you need a top quality uterus and the surroundings. I call this the field of the farmer. You need the seed and you need the field. And that has to be as close to perfect as possible. We should not ignore the field. We've been ignoring the field. We've been focusing in the last 25, 30 years on the embryo, and we've been ignoring, even now we ignore the field, I think, and we need to check our field. We need to check the uterus very well. We need to, in my opinion, all fertility patients should undergo advanced gynae ultrasound scan. They may see things that they're not aware of them existing. So good uterus, good endometrium, good surrounding the tubes. If we have hydrosalpinx, it's game over. I mean, it's 30 to 50% miscarriage and 30 to 50% failure together with ectopic pregnancy. So, we need to be sure that the uterus and the surroundings are normal. And then you need a good climate. So it is again like the farmers. You need the seed, you need the soil, and you need the climate. What is the climate? It's the hormones. The hormones, they need to be perfect, as near perfect as possible. It's the general biochemistry, your vitamin level, your biochemistry level, standard simple tests. It's the thrombotic factors. So if we feel that it's becoming a little bit complex, let's check the thrombotic factors. Do we need to use some blood thinners or not? And then it's the immunology type of climate, so which is the microclimate. So that's all we need. So most of you guys, and thank you so much for listening tonight. You know all of that. So try to individually perfect every aspect. There's 3 aspects: the seed, the soil, the climate. So on that note, I would like to thank you all and give you the very best. You're amazing people. I'm grateful because I have learned so much from those webinars, from my patients, from my team, from people like Rachel. Thank you, Rachel. Thank you for organizing that.
Thank you for joining us, Dr. Tsakos. Much appreciated. And for anyone listening, just to remind you, this will be available to watch from tomorrow on my IVF Answers platform and also on the YouTube channel. But have a lovely evening.
Thank you. Bye-bye.